looking at the process of, how a T cell becomes a CAR T cell, and a little bit better understanding of what those clinical considerations are. I am a full-time employee of Legend Biotech. What I'm going to present here today is regards to CAR T, so chimeric antigen receptor T cell therapy, more specifically in relapsed refractory multiple myeloma, but in general, with unbranded deck, but no medical advice, or we're not going to speak about any specific treatment products by name. Patients and caregivers should always direct those questions seeking medical advice to their healthcare provider. We did not solicit this information. Going through kind of helps support what the interest here is in the community. So we appreciate you guys joining us. We'll go through a couple of objectives, goals, kind of having an understanding of, what is CAR T therapy? How does it work? We're going to then look at the description of what is that journey for the patient? What does that caregiver journey look like? How does a patient receive CAR T? Who is eligible for CAR T? And then as we go through that process, we're also going to gain a deeper understanding of why the patient support system is very crucial to the success of the patient's journey, and understanding a little more about the safety, the considerations to think about, what are those side effects, and kind of what is that monitoring period that the patients may take a look at. The CAR T patient care team can be one of these two or two together. So typically, CAR T is an approved treatment center. Some CAR T products go through something called a REMS program, just specifically for safety. But really, the main thing here, as you can see in the middle, is communication is key. So no matter if it's from the referring oncology practice to the CAR T treatment center, in the middle there, I always place the patient and the caregiver because it's very important to have them always being part of this conversation. If you come from a referring oncology practice that is not at a treatment center, then that referral would come in from that referring oncology practice. We would educate the patients about CAR T. Very similar things we would do in the treatment center as well. So some of these mirror each other, but we want to make sure that the referring oncology practice starts that education with the patients, helps to coordinate those referrals. Maybe they start to screen some of the patients so that the provider can say you possibly could be eligible for CAR T, and then the referral would go over to that CAR T center. And then usually once they're at the CAR T center, they get referred back for long-term monitoring to that referring oncology practice. If you start at the treatment center and there is no referring oncology practice and you stay there, they'll continue on with that process with education. If there is a coordination of patients and consultations and treatments that they have to go back to referring oncology practice, they will. But they'll also look at helping manage treatment logistics because there are some times where you may have to come to the CAR T treatment center on specific dates, whether it's every 6 months or once a year. Once you're released from the treatment center, they'll have an idea about that. Bridging therapy. So typically when your T cells are collected and sent off to the manufacturing facility, there's a possibility that we need to keep your disease kind of stable. And the providers may ask for you to have some bridging therapy and have those discussions. They may want it done at the CAR T treatment center, but they may also allow the referring oncology practice to do the bridging therapy. So that is an option that the treatment centers would have a discussion with you about. The administration of the product, the CAR T product, actually will happen at the CAR T center. They're going to monitor the patients typically up to around a 30-day window post CAR T infusion. And then once the patient is stable and able to be returned back, if there's a referring oncology team, the patients will go back. So we'll go through just a little bit with immunotherapy. Again, we're going to talk about several different possible treatment options that you may see out there. So fortunately, over the past few decades, we've seen some great development of immunotherapies that help the immune system. We're harnessing the ability of that immune system to recognize and attack those cancer cells more effectively. So you may see some of these names, and on the left there you see the tumor cell and kind of all the different immunotherapies, what they do and how they work kind of in a broad term here. So the BS, ABS, those are the bispecifics. They have two specific different binding domains. One will bind to the tumor-associated antigen, so what that tumor is expressing, and the other one will bind to the T cell, right? We need those T cells to help us fight to allow that activity to attack that tumor cell directly. And then you may see a subset of bispecifics, possibly called BiTEs as well. So that might be something that you may have conversations with your providers about. We'll also see antibody drug conjugates, also referred to as ADCs. Those will have a monoclonal antibody linked to some type of a cytotoxic agent. And what that does is it connects itself to the tumor cell of what that is expressing. So if it's expressing BCMA, for example, it'll target the BCMA if that's what is designed to do. And then it'll internalize, and then that linker will dissolve, and then that cytotoxic agent will be released, which the goal again here is always, through that DNA damage, we want to cause that cellular apoptosis, that cellular death of that unfortunate tumor cell, right? We don't want those cells to be there. And then another option, which is what our main topic today will be specifically about CAR T, so chimeric antigen receptor T. That involves taking the patient's T cells, genetically modifying them in a manufacturing facility to have them recognize a specific antigen, so something that that tumor cell is expressing, because once it's infused back into the patient, the goal again is always to identify and eliminate those tumor cells. All right, so what actually is CAR T? How does it work and what does it do? And this is a simple little picture here, but it's really a lot more complex. But what our goal with CAR T cell therapy is we really want to harness the patient's own immune system because we know that that can help fight the cancer. But unfortunately, right now, when you have a cancer diagnosis, if you have multiple myeloma, for example, those T cells really aren't doing the job they're supposed to be doing. So what we see here is we can have those T cells then through manufacturing process at a facility will become those CAR T cells. So the patient will have leukapheresis, so they may have some type of a central line placed in. Sometimes it's the morning of those T cells, those white blood cells, right? We'll collect those cells. Takes a couple of hours. We'll go through each of these steps too a little bit later in the presentation. We're going to collect those T cells. Those T cells are then sent off to a manufacturing facility. They do a lot of vigorous testing, have a lot of parameters that those cells have to make in order to then allow that T cell to have that chimeric antigen infused into that. And it's typically done through a viral vector process so that that genetic material can be introduced to that T cell so that it can become that CAR T cell. So that's how those T cells become those CAR T cells through that process. And then there's a lot of checks and balances. Like I said, we'll talk through that manufacturing process. So what we want to do then is those cells are genetically modified. We watch them, they grow, they proliferate, they're sent back to that treatment center, and then the patient will be ready to have that infusion occur. So we really, again, want to modify those T cells. We want to collect the best possible amount and type of T cells that we can because we do want the patients to have the best possible option by collecting the best cells. So what would a CAR T cell, what would a CAR look like? So this is in general what we would see. So we would have those single chain fragments, that part of the antibody that's going to specifically go after and target that tumor protein that the antigen that that tumor is actually expressing. So that will be done through that extracellular domain. So there's extracellular domain and then the intracellular domain. That extracellular domain is what attached to what that tumor is expressing. So I mentioned that earlier. Maybe if it's a myeloma cell, maybe it's BCMA, for example. Then we have the T cell membrane, and there's a hinge that's going to connect the extracellular domain to the intracellular domain. Those intracellular domains, that part of it is what's going to stimulate the T cells, what's going to help those T cells activate, going to help those T cells grow and proliferate and continue to do the job to target and cause that apoptosis to occur. So you'll see that in the next slide here is, how does that activation occur? How does it recognize it? Again, we've manufactured those T cells with the CAR. So those CAR T cells now, when they're infused back into the patient, have a specific job in mind of what they need to do. So it recognizes that specific protein that it's designed to go back once it's infused on that tumor cell that's being released. And you can see the tumor cell with like those yellow little prongs sticking out of it. That is the tumor, that is the antigen that these CAR T cells are designed. So that CAR T, as you see that dual binding on the extracellular domain, links to that antigen that's being expressed by the tumor cell. and then I say the magic happens, right? That's where the activation and the cellular proliferation occurs. Once it links in there, there is going to be that release. Once that activation and proliferation occurs, we're going to have a release of those lytic molecules. Those lytic molecules, those are those specialized proteins that actually cause the tumor, the cancer, to actually die off. So those cells, those increase in those cells, that proliferation occurs. Those T cells, they grow in number, they activate those cytokines. Obviously they promote inflammation, but we have to make sure that we keep some things under control, which is why we'll talk about in a little while with regards to safety. We want to, monitor those adverse events that patients are having. The goal here again is to stimulate and cause that eradication, cause that tumor cell death to occur. We do know that CAR T cells can persist in the patient's body for weeks or months, or possibly even longer. That's where the research is at right now to see how long those cells are continuing to grow and activate and proliferate and cause that, tumor to not be recognized, where the patients can be in longer remission with one simple, I say simple, but a very in-depth, infusion to occur. We are seeing many areas of development in diseases and illnesses with CAR T. It may not be a comprehensive list, but just so you have an idea, we see it in solid tumors, we see it in hematologic malignancies. It's being studied in many different viruses, some fungal infections, and several different autoimmune conditions. So we are seeing a lot of research in the CAR T aspect of things to see how we can actually make a difference in some of these different diseases and illnesses within the patient population, as you see on the screen. So basically, what is CAR T? How does it work? We talked about we're going to collect the patient's cells. They're going to be sent to a lab, a manufacturing facility. They're going to be genetically modified specifically with a target in mind once it, being expressed on those tumor cells, because it is a single infusion that gets infused back into the patient. We talked about that extracellular domain. That is the area that recognizes what that tumor, protein being expressed is on those malignant cells. And internally, that's where the activation of those T cells occur, continuing to see that expansion and that proliferation, as well as the elimination of those targeted tumor cells. All right, so now we're gonna, understand a little bit more about what the CAR T process is now that we know how a T cell becomes a CAR T cell. So we're gonna kind of follow through with the journey here. How would you know if you're eligible as a patient? What would the provider take a look at? What do you need to understand? There's several different areas that we're going to take a look at. If there is a clinical trial, the provider's going to want to know, do you meet the inclusion criteria? If it's a commercial product, are there specific things in the product label that the patient has to either have been exposed to, possibly be refractory to, or maybe, refractory meaning that the products don't work anymore for their disease. So there are certain conditions that might need to be met with products if they're commercially available. We're also going to want to know, because those T cells, when they're collected and sent to a manufacturing facility, that could be a window of, 2 to 6 weeks, give or take, depending upon the product. But can the disease be under control while we wait for those T cells to be manufactured in the lab? Or will we be able to do some bridging therapy to kind of keep the disease at bay, keep the patient in a good performance status where they're, pretty well off to do their own activities of daily living? The same status when your cells were apheresed. The goal is to keep the patient, when it's time to get those cells infused again, to keep the patient in that same good health. So we're looking at an ECOG performance status is what the providers would take a look at. We always need to have a really great support system for our patients, and we'll understand a little bit more later on. Sometimes it's more than one person. So if you're at a CAR T center and they want you to be hospitalized for 30 days, sometimes we may not have one person designated as our caregiver that can stay with us for the full 30 days. So we may have one person for 1 week, a second person for the second week, and vice versa. So as long as everyone that's part of the patient's journey has an understanding of what to expect and understands who to call, it's just really important that we have a really good understanding of all that from all aspects, but also continuing with that communication part being key. We just really want to have someone that can advocate for the patient and understands and knows the patient from the beginning throughout the process. Um, of course, you have the diagnosis. Again, if it's a commercial product, if there's a hematologic cancer, we want to know if that product is the patient needs to have that diagnosis. So maybe there's labs. We're going to check the organ status. There's some scans. There may be a bone marrow biopsy or maybe a tissue sample if it is a solid tumor, for example. There's several logistical considerations. So if you're not close to a CAR T center, is it too far for you and your caregiver to drive? Can you stay at the CAR T center for those 30 days or within that radius window? If it is an outpatient center, there are areas where you need to stay within a certain mile radius. Can they drive back and forth for those 4 weeks? Again, there are specific parameters at some treatment centers that you have to follow. And again, depending upon what those parameters are to know if it's a good fit, for you and your caregiver and your family. Does the patient need resources? Does the caregiver need resources? There are many programs, I should say, that CAR T manufacturers do typically have really good, robust patient support programs that can help with lodging, traveling support, and possibly other resources. So it's always good to ask those questions. They may also include the caregiver, not just the patient that might need support, because again, you may have, people from other states that may have to travel. You may have to take time off work. So again, just take a look at that consideration and have that question. If you are going back and forth from a referral oncology center to a treatment center, do we need bridging therapy? Where does the leukapheresis occur? Do I have to go to the treatment center? Can bridging therapy occur at the referral center with the oncology, or do I have to go back and forth to the treatment center? So again, some logistical considerations that really have to go into play so that we understand, are you the right fit for CAR T, for example? Can you and your family, your caregiver, kind of work through the logistics of it all with the schedule? So the process here, we're going to go through each of these sets of steps, excuse me. The patient's journey will begin with that referral. So whether it's from the referring oncology or the patient goes into the treatment center, eligible patients will then, get a workup at that treatment center and be reevaluated for their eligibility. Again, communication being key between all aspects of the care team. So the referring oncology, the treatment center, the patient, the caregiver, the patient's family as well. So the first step we talked about would be that performance status. We're going to try and collect the best possible amount and type of T cells we can. We know you have cancer. It sounds funny to say we want the healthiest of those T cells, but some products are in earlier lines and some products are in later lines. So we want to try and get the best possible collection as we can because we know the patients will have a better outcome if we have the cleanest of the cells that we can collect for the patient. So the goal here is always to keep the patients at the performance status that they were at when we first collect the cells to later on you see in step 5 where we're going to infuse those CAR T cells into the patient. So we want to try and keep the tumor and the cancer at bay and keep it stable, but we want to keep the patients at the same performance status to be as healthy as we can be. And the next slide will go through kind of some of the washout periods of specific products in general for CAR T, but some products may have different washout periods. So this is kind of more generalized. So the leukapheresis will happen. The cells will be sent off to the manufacturing, which is that number 3 right there. But in the meantime, we talked about it. Some patients may need to undergo bridging therapy. I'd love to say that your cancer is going to hold on and we can wait for this manufacturing to occur. But unfortunately, we need to make sure that the disease, isn't too aggressive. We need to make sure that it kind of stays a little bit under control. So we want to have that bridging therapy. The provider will be the one to take a look at if you've had previous therapies, and give you an idea of what would be the best possible bridging therapy option. A couple of days before you're ready for your T cells to be infused, something called lymphodepletion therapy will go on. Usually it's cyclophosphamide and fludarabine. Again, the goal here is we just want to keep that bone marrow clean. We want to have the patient's body to be the best host possible. So we'll go through lymphodepletion therapy in a little bit. And then on day 0 is the infusion of the CAR T cells. Some treatment centers have you admitted if it's an inpatient. On day 0, there may be some pre-meds. The CAR T cells are usually, frozen. There are some fresh ones, but typically they're frozen and preserved in a preservative. And sometimes you may see some reactions, infusion-related reactions occurring. So there may be some pre-meds, antihistamines, Tylenol, those types of products, for example, that may be consistent with what the label would require for you to get beforehand. But the provider will take a look at and, understand if you have any um, allergies that may, prohibit a certain product from, being one of those pre-meds, and there's usually alternative options. And then monitoring happens after the infusion and long-term follow-up will occur. So that's where the communication continues between all parts of the patient's journey, all individual parts, referral, treatment center, patient's journey. You'll have a schedule and have an idea of when that follow-up needs to occur. And this is what I was talking about earlier with regard to that first step. Before leukapheresis occurs, there's typically a window of when we want certain products to stop, certain medications to stop before we collect your T cells. We really want to make sure that we don't have anything that's going to affect the quality and or the quantity of those cells that are being collected and being sent off to that manufacturing process. So you may have to stop immunosuppressants immediately. If there's any chemotherapy or immunomodulatory agents, it's typically a 2-week window that the providers will say, let's hold off on, doing that because we want to give those T cells the ability, to be as strong and healthy as they can be. Usually steroids are greater than 72 hours before the leukapheresis occurs, and the same thing with anticoagulant therapy. So always have your provider know what type of vitamins, what type of supplements, what type of herbal remedies, anything you're taking over the counter can also be affected here, not just products that are prescribed by a doctor. I jokingly say you can literally get anything off of Amazon. So if you're having a cream, that can also be affected and go into the circulatory system too. So we just want to make sure we give the patients the best opportunity for those T cells to be the healthiest that they can be. That bridging therapy, again, the goal here is to have that disease under control. Some patients, it may be required. The provider would be the best one to do that. The goal, reducing that tumor burden, continuing to maintain that performance status. We want you to continue to be able to do the same things you were doing when that apheresis process occurred, because when that infusion occurs, there may be areas where we need to, include that multidisciplinary team. We want to keep that disease under control before that lymphodepletion therapy and CAR T infusion occurs. We want to keep the patient to be, as strong and healthy as we can be ahead of time. The manufacturing is a process that may take anywhere from 3 to 6 weeks. So those cells are collected. We do isolate those T cells out of that white blood cell, right? That collection may have, a 3 to 6 hour window, possibly at the treatment centers when the leukapheresis collection will occur. Those cells are sent off to a modification, a manufacturing facility for that genetic modification. And I should have said this before, but there is a whole schedule within the CAR T manufacturing process to know when you can schedule for the cells to be picked up, when the cells will be at the manufacturing facility, and have an idea of kind of where that process is, and then when the cells will be sent back. So there's always a lot of communication between the treatment center and the manufacturing facility of so the patient so the I'm sorry the treatment team has an idea of when to schedule for you to come back to be infused, and then they have the idea as far as timing of bridging therapy and lymphodepletion therapy, because it does usually lymphodepletion therapy is typically done a couple of days before the infusion is, but the bridging therapy may happen sooner. So when those cells are sent off to be genetically modified, they're typically frozen, so we do have to thaw them. Then they get activated. We watch those cells. They're going to be genetically modified with that viral vector process to express that chimeric antigen receptor. So you can see that T cell now kind of has two prongs, where before it just kind of had one little prong. So they are then going to grow and expand and proliferate. And you can see from that third picture there, lots of T's in that little petri dish kind of circle that you can see. They're going to have to go through a lot of checks and balances, a lot of QA, a lot of quality improvement, quality assurance checks. We want to make sure that we're collecting the best of those cells. That testing then allows those cells to be collected and packaged based off of whatever the parameters are within that product. So there are specific parameters that we take a look at when we're collecting that, and then they will be ready to be shipped back and cryopreserved back to that treatment center. Lymphodepleting chemotherapy will happen a couple of days before, have an idea of when that schedule will occur, and then that administration of that single infusion will occur with those CAR T cells. And this is what I referred to earlier. So it's a couple days out that CAR T cells are being manufactured in the lab. We know things are moving along nicely. The patients may have to come through and get some lymphodepletion therapy. The goal here is we want to prolong the persistence of those CAR T cells once they're infused back into the patient, and we want to increase that effectiveness of the actual treatment. So we're really trying to get the body to be the best possible host to have those CAR T cells back infused back into the patient so that they can grow and proliferate inside the patient. And I said this earlier, and it could be months, to years possibly of when that continued to happen. So typically it's a couple of days, 3 to 4 days. Most of the time it's cyclophosphamide and fludarabine that are used. Again, the provider's going to take a look at your kidney status, your renal function, to know if there needs to be any dose reduction to make sure that you can actually tolerate the specific treatment there. All right, so lymphodepletion therapy happened. One of the last steps here is the infusion of those T cells. Typically, we refer to this as a day zero. That infusion is going to occur. The manufacturing product information may have specific medications to be used for pre-meds that I mentioned earlier. We really want to try and alleviate any type of an infusion-related reaction with that preservative that those CAR T cells are maintained in because they're cryopreserved, sent back. There are some fresh cells, but typically they're cryopreserved. Most of the time, they are going to be thawed at the facility when it's time for you to get the infusion. And we know that once those CAR T cells are infused, they're going to continue to expand. And we may see some reactions that are going to occur possibly immediate when that infusion occurs and may have that long-term monitoring to occur. So your CAR T infusion can happen inpatient or outpatient, depending upon the certified treatment centers process, because we do have some outpatient facilities as well as some inpatient facilities. Some CAR Ts are still under the REMS for safety reasons, so they are specific to certain centers. The monitoring aspect of this is kind of one of the last steps. So typically your infusion occurs at day zero. We're going to really continue to take note to see if there's any adverse reactions. Typically we'll see, cytokine release syndrome and ICANS occurring. If the patient can tolerate and is doing well, they may be released after 30 days from the treatment center and transitioning back to their referring oncology. That process then continues on with long-term monitoring, and the communication is key here between the certified treatment center and the referral, because there are going to be times where you're going to have to return back to the CAR T center for specific intervals, maybe for the first couple of years. Again, each treatment center may have a different protocol that they follow, but that communication will be key because we want to continue to monitor for those toxicities, those adverse events for a long time. But we also want to make sure that we're checking, for disease progression, disease relapse, maybe the disease is under control, and there's really good quality of life that can happen with the patients moving forward. So, kind of when we're transitioning that care around that 30-ish day window, we really want to make sure that, the patients are going back to their, referring oncology practice with a grade 1 or lower adverse event. So some type of side effect that's a lower number for that transitioning to occur. So you'll have something called a wallet card. You may have it, your caregivers may have it, your family may have it. It's very important to have that on you if you are the recipient of a CAR T product. You may go to a local emergency room, you may go to a quick care, you may be on vacation. This way, wherever you're at, if something is happening, they have an idea of what you've received so that they can take a look at that. They may want to have a look at the prescribing information or any type of medication guide. If you have a list of your medications, we are going to also transition over with regards to hospital records. It's important for that, transition of care to occur so that the, referring oncologist knows what happened, what were the notes, what type of adverse events, if there's any new staging information, what type of discharge information, what type of support care was given if there were any adverse events, and then how did the patient respond to them. We'll also have an idea of what types of labs need to be drawn. There may be lowering of counts, chemistry panels, CBCs, differentials, many different things can be drawn, and taking a look if you do need any type of blood products. So support care platelets, red blood cells as well. Maybe there's also something for your white blood cells, some growth factor. And then having a real idea of when should they follow up at the treatment schedule? What does that, treatment center, excuse me, what does that schedule look like? Always including communication being key for all of this within all of the systems there. There may be, some steroid use. There may be hypogammaglobulinemia where you get the IVIG infusions. You always want to know who to call. So there should be a point of contact between the treatment center and the referring physician's office for the patient, for the caregiver, but also for each of those two doctor offices as well. So the treatment center knows, who is the main point of contact at the referring office as well, vice versa. And it's important to always understand, their primary oncologist more often is being the one that will follow up, and the treatment center may become less and less if they continue to go back and transition back into, the community, into the referring office. So the caregiver and the patient and their family, because there may be more than one caregiver, like I mentioned earlier, it's really important that we make sure that everyone is educated on kind of what to expect, understand where the patient is at, and then be vigilant with reporting anything that is different that the patient experiences from the moment that that infusion occurred. And speaking of that, let's just take a look at some CAR T safety. Again, this is in general some of the adverse events that you may see typically with CAR T infusion. We're very familiar with the class effect of, cytokine release syndrome, CRS, with our CAR T products. That is that activation and proliferation of those CAR T cells when that infusion occurs, back of those CAR T cells. Looking at that cytokine, it's an inflammatory process that's going to cascade from those lymphocytes. The toxicity typically is those higher level of those serum kind, the IL, the interleukin levels, I should say, those inflammatory markers. We have grading scales that we take a look at to know based off of, how high the fever is, how low the blood pressure might go, what type of oxygen does the patient need, a simple, burst of oxygen or more of a mask, having an idea of what we should do. Typically, those symptoms can appear, right from the infusion to possibly 14 days following the infusion or later. We're going to take a look at that. We do have some things that we do manage. Typically, patients start with a fever as one of, the earlier signs, symptoms, I should say, that we'll take a look at. Um, may need some oxygen, blood pressure. They may have some shakes. We're going to take a look at the organs, see if anything, if there are any issues or dysfunctioning of the organs, and providing supportive care. So how do we manage that? There's a product called tocilizumab, which again is that product that's approved at the treatment centers to be given. Each treatment center has its standard of care of when they would give tocilizumab if there were fevers. Tocilizumab's goal, right, is to decrease those inflammatory markers, those interleukin markers, because we don't want to have that cytokine levels to be really, really high. It can be very dangerous. They really need to keep them under control and keep that being monitored. Those cytokines are those proteins that can control the immune response. So whatever supportive care the patient will need, we'll take a look at that. But there are warnings within the approved CAR T products, and some of them are kind of a class effect, like CRS may be. And I referred to this earlier, the American Society for Transplant and Cellular Therapy. This is the grading scale that the providers will take a look at to know what type of intervention we need to do. So if you have a fever, if it goes above a certain degree, that's considered grade 1, grade 2, grade 3, grade 4, as you can see on the screen. We're going to take a look at your blood pressure. What type of support do you need? That is also going to grade that CRS. And as far as oxygen goes, well, does the patient need more oxygen? Is it a simple nasal flow cannula, or do we need more advanced support for the patient? And to know kind of what the supportive care is going to be based off of that grading. Other neurotoxicities that you might see might include something called ICANS, immune effector cell-associated neurotoxicity syndrome. What we're going to do here is your centers are actually going to do some things called ICE score. So we're going to take a look at, if the patient is having some type of an adverse event, This can happen with or without patient going through CRS. You know, maybe the patient didn't have a fever, but now they're not able to speak. They're kind of a little more agitated than normal. Maybe there's some delirium, some weaknesses with the motor. So that's where these ICE scores come into play. What we're going to see is some supportive care. Maybe, you know, again, if it's a neurotoxicity, we may have to do some non-sedating seizure prophylaxis, look at some lumbar puncture, look at some brain imaging. We want to know what's going on. Maybe there's corticosteroids. So we're really going to continue with monitoring. This is where the monitoring comes into play for lifelong monitoring of our patients with secondary malignancies as well. Underlying, you know, taking a look at the disease, looking at those secondary side effects as well, and knowing kind of where that's all at. In regards to ICE scores, if the patient, you know, the higher the score, really we take a look at the more neurologically fit our patient is. So they're going to do this at specific time frames, not just at the treatment center, but may also be something in the outpatient facility, or could even be something you're having done at home when you're at home and you follow up, you know, through some type of charting system you may have. So the higher the score, the more neurologically the fit is. Really, encephalopathy is a broad term that really we take a look at the brain disease and kind of what can alter the brain function and what can alter the brain structure. So you'll get points for each of these. So if you can name the year, the month, the city, the hospital, and you'll get 4 points. You know, if we can look at a couple of nouns, name 3 things, you get a couple of points. Follow this simple command, show me 2 fingers. If you can write a sentence, so they're going to have the same sentence they're going to have you write, and they're going to look for like micrographia. We're going to look and see if, you know, now your signature is not legible anymore, but before it was. And then can you count backwards from 100 by 10? So 100, 90, 80, or do you have to take a minute and think really hard to be able to focus and concentrate on that? And this is where the scoring comes into play. So taking a look, again, highest score being 10, if you are unable to count backwards, maybe you get a grade 1, for example. If there's a depressed level of consciousness where you awaken spontaneously, but it's a little bit more of a delayed, you know, response, they may look at a grade 1. Obviously, if there's a seizures, we may go over to grade 3, looking at the motor function, looking at the writing, and then headaches and more cranial pressure. We'll take a look at what those scores are. And then there's specific parameters that we'll take a look at to see what might need to be done. Adverse reactions can occur from, you know, the moment the infusion occurs to 4 weeks post-infusion to, you know, long-term, like we talked about. We want to look at, you know, higher risk for infection, always taking a look at the patient's counts, looking at their chemistry profile. There may be some electrolyte imbalances. Your caregiver may very well be the first one that's going to notice some of the agitation, some of these things more so than the provider, especially because your caregiver's with you, you know, those 24 hours while you're sitting in the hospital room where the medical team may be in and out. So it's really important to notice any of those subtle changes in the patient's, you know, neurological status or ability to do things. If there is any confusion, any difficulty breathing, you know, we'll provide that supportive care. But the sooner we see any of these adverse reactions, we want to provide that supportive care as soon as possible. Some other side effects that can occur possibly 4 weeks or later. We'll see some cranial nerve palsies, immune-mediated myelitis, Guillain-Barré syndrome. Secondary malignancies might be something later on you might see as a box warning with all CAR-T products. Peripheral neuropathies. Parkinsonianism is more of a movement disorder. Doesn't mean you're going to get Parkinson's disease, just a little different. You may see some prolonged or recurrent cytopenia, so your decreased counts. I talked about that earlier with red blood cells, platelets, white blood cells, for example, taking a look at that. We talked about ICANS, we talked about CRS, increased early mortality may also be something in that side effect profile. And then looking at continuing to monitor that fever, because if the counts are going lower, we could have some serious infections with febrile neutropenia. Patient-related considerations, we want to take a look at that patient support. This is one of the more important areas of this journey. We really want to make sure that that patient caregiver is there for encouragement, emotional support, helping with daily assistance, really understanding what is the product? What are the side effects we should be looking for? Who's part of the multidisciplinary team? Again, looking to know who to call and when to call is really important when we see that. So before treatment, I think I want to stress this a lot. It's really important to understand kind of what the expectations are from the patient side to the caregiver side, because when you're going through the treatment and you're not feeling very well, the caregiver's role is just there to help support you in the best ways that they can. But if you can have clear expectations and clear communication as the patient to say, I want my bed made like this. I like this type of a meal. I like this type of bread. This way, those simple little things can alleviate any anxieties and tension. Really, the caregiver's there to help support you in the best way they can. And if they're unsure of what your expectations are, we want to make sure we're, really honing in on that partnership, because we can help, really make that journey be so much more successful during treatment, making sure that they can drive back and forth to appointments, managing appointments, really being that head point of contact between all the providers. And then after treatment, knowing what to look for, being educated on that, remaining with the patient for those extended periods of time. Again, they may be the one doing the cooking, the cleaning, the household general care that you may not be able to do as the patient. A lot of the products may have an 8-week window that you may not be able to drive or operate any type of heavy machinery from the infusion date. So it is an area of concern for safety that we have someone that can commit to providing you with those services. And then this will be my last slide here, and I'll turn it over to Valerie. CAR T cell therapy in general, we're taking a look at what is, a T cell becoming a CAR T cell, looking at the coordination between the referring oncologist and the CAR treatment center, excuse me, who's eligible for CAR T, understanding what that label requirements are, if it's a clinical trial. Do we have a care partner? What is the expectation of that care partner? Can they meet those expectations? Do we have a good communication between the support of the treatment center and the referring oncology center? And then understanding some of those toxicities, cytokine release syndrome, ICANS, other adverse events, so everyone's aware of what to expect, and then continuing with that monitoring. So that is my last slide, and I will turn it over to Valerie. Thank you.
Thank you.
And I'll stop sharing then, Valerie.
All right, and then I'm going to get the screen back up here. So we're going to go into our Q&A portion right now.
Sorry
Great.
about,
Yes.
sorry about, just move your notes to the other part because right now we're seeing, awesome.
Is that better?
Yes, we just went back to slide.
Okay.
We just went back to slide number 1 if you want to skip a few, but your screen is perfect.
Let me go back because I'm on slide number 10. So let me see what's going on here. What slide do you see now?
Well, still on number 1. Welcome to HealthTree's Black Myeloma Health Community Webinar.
Okay. Well, not sure what's going on there.
Do you want me to share my screen?
I think that would be better. Yes.
Okay.
But we're going to move on with the Q&A part. I hope you all have some good questions. Cheryl provided a lot of great information. So you took away my notes. So I'm going to go ahead. I see that there's a question there while we're dealing with all the technical stuff in the background here. Cheryl, there's a question about what does a washout period mean? Perhaps we can.
Sure. So washout means the time that you may have to be off a specific product. So, on that one slide there, it referred to specific products. So we want you off of those products because it may affect the ability of your T cell to be the best possible T cell it can be. So if you're on chemotherapy or immunotherapy, we have a washout window, meaning you can't use those products for that amount of time because we're preparing you specifically for, that apheresis part to collect those T cells. So did that help answer that a little bit more for you?
If not, we can come back to that. You can just respond in the chat there. So here's another question. I'm 8 months post-transplant. Will my white blood count get back to normal? So
So
not
transplant's a little different than CAR T cell therapy. So that would be something I would suggest you speak to your provider about because I'm not quite sure your diagnosis, what type of transplant, allogeneic, I should say, and then what other type of treatments you had because transplant's a little different than CAR T cell therapy.
awesome. Thank you for that. So, Cheryl, one thing that for those of us who have heard of our CAR T before, when it first came out, there were a lot of difficulty in having to wait the manufacturing times. Can you speak a little bit about that? And has that improved at all? What can patients
Yes.
expect?
So, a couple of things have helped improve that. A lot of the manufacturing facilities now have many, many slots available. And that was one of the things where you have a couple of manufacturing facilities in the US, for example, and all of the treatment centers were trying to get into the slots of what's available. So now the manufacturing facilities have a lot of available slots for the patients so that the treatment centers can fill in the blanks with those slots and not feel like there's no options. And as we continue to change and grow within those manufacturing facilities with all of the requirements, we are doing our best to continue to have that window get shorter and shorter. But again, we do have a lot of quality checks and balances that we really need to make sure that we gather and collect the correct T cell that meets what those parameters are. And we also have specific parameters with regards to those T cells that are now CAR T cells, where we have to look at the patient's weight as well. In order for that infusion, to be considered that commercial product, it has to meet some of those parameters with the numbers of T cells that are collected based off of the patient's weight also.
Awesome, awesome. Um, this is, could you speak to the higher risk of infections post-CAR T?
Yep. So in general, most of the time with your hematologic malignancies, patients are naturally at a higher risk for infection just because of the hematologic malignancy. Whether it's myeloma with plasma cells, you're at a higher risk for infection as well. And sometimes what we'll see that correlation when we have those cytopenias I referred to earlier, which means your lowered counts. When you don't have those white blood cells, we want to make sure that you are watching yourself for fevers and being at a higher risk for infection so that we do provide you with that supportive care, not just for anti-infective, but we also maybe need to do something with neutropenic. You guys probably heard of, neutropenic precautions with regards to some type of white blood cell support. So growth factors, on pros, there's different kinds of boosters as well. So a couple of different products that the providers could do. You may also need to do those IVIG infusions if you're in the myeloma space, for example. That higher risk for infection, those IVIG infusions can continue on as well.
Okay, thank you.
Hmm.
So, sure, we know that the CAR-T has done a lot at teaching and academic institutions, but many patients are, they don't live there, those types of treatment facilities. So, what does that process look like for someone who may be living in a rural area?
Sure.
Um, could they start at that teaching institution and then have the care transferred back? Can you talk a little bit about that?
Correct. So again, you want to make sure you have a caregiver that can, do those logistics of that transportation. And your provider may also then, in a referring oncology, specifically having you go to a treatment center that's as close as possible to you so that, we break away from a 12-hour window. Maybe there's something 4 hours in some of those rural areas. And that's where that communication comes into play between the referring oncology center and the treatment center as well, making sure that everyone's aware of kind of how things are going, what has happened, making sure they have access to the records. So when patient is discharged back to their local community, the goal always is to have the patients be as comfortable as they can be in their home environment as safely as they can be, as soon as they can be. So you really, have this idea of around a 30-day window, give or take, depending upon how the patient's doing, where they may need to stay a little bit longer by the treatment center if they're not well enough in the provider's eyes to then be sent back home in that rural community and then have that follow up with that referring oncology provider.
All right, that's good. Hopefully that's, going to be a game changer for many who are out in rural areas or not seeing,
Exactly.
um, a teaching.
Right, right. And not having access to it because your doctor doesn't do it in their practice, in their outpatient community setting, for example, doesn't mean you wouldn't have access to it, but through them, they could refer you to that treatment center because it is a viable option that may very well have some, phenomenal effectiveness, overall survival, progression-free survival scores, numbers, percentages that's going to, have a great impact on your quality of life.
Thanks. So we have a question about the cutoff age. Is there a cutoff age for CAR T therapy, as there sometimes is often referred to in the stem cell transplant?
Not necessarily. That's going to be patient provider specific. So, there are some 70-year-olds that are fit as a 50-year-old, and then there are some 50-year-olds that may feel like they're 80 and have some, organ damage and things. So it's not necessarily like we say, age isn't a number necessarily where we would think of that. That's where you would go and be evaluated to see if you are eligible for it. So, don't assume because of a specific age you may or may not be eligible. The providers at those treatment centers will evaluate you and do all those testings just to make sure that you are a good fit for it.
Actually, good, good. So how long can you be in remission after receiving CAR T therapy?
That is where the research is at right now. So, depending on your diagnosis and depending on the treatment product, you may be in remission for years. You can be remission for months. Now, that is the average of what we see in some of our clinical trials, for example. So, not everyone's going to have the exact response, just like you would with any chemotherapeutic agent, that you may receive, where, your neighbor responded differently than you did, for example, because every patient and every disease may be a little different. And in the myeloma space, some of the products are, it may be approved in that second line, third, fourth, fifth, sixth, seventh, eighth line, but it's, currently approved in an earlier line. And typically we see a better outcome with patients that just aren't so beat up from so many lines of treatments, but it may still be a viable option. So again, the providers will tell you that. So there is no set number because some of the products progression-free survival average hasn't been met after, 3+ years, for example. Patients are still living with multiple myeloma and have not received active treatment except for that one CAR T infusion. So it really will have a phenomenal impact on your quality of life where you're just going in for supportive care versus going in all the time to have all these other treatments. So it's really, as a nurse, one of the nurses shared with me one of the best compliments where you could tell a patient, go on and live your life, because the patient wants to know, well, what's next? And what's next is continue to live your life. There isn't, more treatment until your disease progresses or you're not responding anymore. Then the labs and, your symptoms and some of the scans will show us we need to do another treatment. But in the meantime, it's remarkable to be able to say that to a patient.
Yes. And speaking of which, I mean, I know you just mentioned you were talking about the lines. It's a good question. So might the CAR T therapy replace the auto stem cell transplant in due course? As for example, be the first line of treatment following induction treatment.
Well, more to come. That's where the clinical trials are at. So, more to come with regards to that. So, keep your eyes and ear open on some of our larger conferences. Sometimes some results, are presented. I know ASCO's coming up. There's JADPRO. There's so many different conferences in the hematologic malignancy as well as solid tumors, right? We talked about CAR T being in solid tumors as well. So in the clinical trials world, the FDA has a lot of regulations, and they allow you to present some of that data at specific endpoints. So keep your eyes and ears open on that one.
Yeah, and we have a participant here that says, I'm 3 years post-CAR T with amazing quality of life. So kudos. It's always good to hear
Yeah,
those
that's great.
types of stories there. I got a couple more questions. We will do three more, and then I have one more.
Okay.
So does the latest CAR T target other antigens other than BCMA, as for example CD38? And how would I know if I have BCMA antigen?
Okay, that's a great question. So there are CAR Ts that are specifically targeting certain antigens that your tumor expresses. So what you need to do is just look up particular products. You can also have that question with your provider. I said BCMA, so B cell maturation antigen, just looking at the multiple myeloma patients, knowing that the vast majority of your myeloma cells do express BCMA, so it does become a nice target, knowing that those tumor cells express that. You will know if you have BCMA. Your provider can let you know if if they're going to do any type of marrow or genetic testing to see what your cells might be expressing. So that's definitely a question to follow up with your provider on.
Mhm. And then there are different CAR T therapies. Are they ranked by best to worst in terms of serious side effects?
Yes, so there are different CAR T therapies. One of the best ways to understand that is go into those product labels on each of the products, and it will share with you from the clinical trials data to know what type of side effects, the grading of the side effects. I showed you guys the slides with the grading of the adverse events, and they'll give you percentages of a grade 1 or grade 3, grade 4, whatever it might be to know, and then you can make the comparison. So typically when a product, not just CAR T, when a product is commercially approved, you won't see a head-to-head clinical trial of this approved product against this approved product. The products go against what the current standard of therapy is, and the product needs to be better than that to be approved in a specific line. So you'll have to just do a little bit of homework based off of what you're specifically looking for.
Yeah. Yeah. And I want to touch base. I mean, we know the importance of having a care partner there when it comes to CAR T therapy. And for many, that's not an option, you know. Are you able to share, how that, those individuals that don't have a full-time care partner or caregiver
Mhm.
can still be able to participate? And what are some of the tools and resources that's available specifically for the caregiver during the monitoring phase of the CAR
Mhm.
T?
Yep. And that's part of that education piece of kind of being part of that journey with the patient from beginning and throughout, and communication and conversations being key. So some programs do have support for caregivers, not just for the patient. So there may be, maybe a taxi needs to be done. Maybe there's a hotel room that needs to happen. Depends on what the treatment center also has access and availability to the caregiver and the patient. So that's where those questions come into play. And sometimes we don't know which questions to ask. So that's a great question to know what the expectation is of the caregiver, and then also what the patient is expecting of the caregiver. Because if it's, every 3 to 5 days a different caregiver, we really need to make sure that everyone is educated in that, conversation flow continues. So it's not like that telephone game where by time the sixth person gets the message, it's a different message. We want to make sure it's the same message. So it could be a journal that's kept at where the patient is at, and that's where the writing comes into play, where each individual caregiver, may have some notes to put in there, and then that journal goes wherever the patient goes, so that no matter how many caregivers that is, it's still the same story that's being reverberated appropriately through caregivers, because it is stressful, and caregivers don't have to be family. Caregivers could be friends and neighbors and church groups. You could have myeloma support groups, right? You can have caregivers, whoever it is that the patient feels comfortable with. We want to make sure that it's the right caregiver for that patient too.
Awesome, awesome. And several people in the chat that have received CAR T therapy and success stories there. So kudos and thank you all for sharing your story
Oh,
there.
definitely. Yes. Love hearing that.
Yes, yes. It's 27 months post CAR T. 20 months post-CAR T, and an 80-year-old. I know there was a question about the cutoff on the age there. So there's someone who's 80 that is, had success with the CAR T therapy. So, Cheryl,
Mhm.
thank you for being with us today. We definitely could not get to all the questions there. Uh, so thank you. Do you have any closing remarks with us this
No,
afternoon?
I just really appreciate you all joining here. I think it's really important. You know, caregivers, patients, you guys are the best advocates for yourself and for your family, friend, loved one. There is a lot of information out there. Sometimes it's a little overwhelming and confusing. So just make sure to ask questions, ask as many questions as you need to have, and really try and make sure that you understand. I think the best advice would be to try and get any type of a written resource if you can. Like I said, that journal, keep that journal with the patient. I think it's really important. We all try and remember what happened yesterday, and sometimes we don't even know what happened, 2 hours ago because there's so much going on in our lives. So having it written down is really going to be helpful for the providers as well. So that would be my best advice. And thank you all very much. And I just wish you all the best of health in anything and everything.
Thank you. Thank you for joining us today, Cheryl. And you make a moment if you haven't checked out the Black Myeloma Health website. I think that's going to pull up there. Yeah, so blackmyelomahealth.org. If you haven't had a chance to stop by and check out some information over there when you get a chance. Um, Next month we are going to be having because it's Juneteenth month and it's clinical research. We're going to be having a panel of patients that have participated in clinical research before. So you can come and hear their voices. They're going to share their experience with us, the good, the bad, the ugly, everything in between there. So note that is on Tuesday, June 24th. I know normally we meet on Thursdays, but for this one, it's going to be on Tuesday. And then on Wednesday, June 3rd, coming up, we have the bi-monthly blood cancer financial Q&A. You get expert answers to your treatment cost, questions around cost and support questions. June 18th at 3 o'clock, there's a webinar, Should High-Risk Smoldering Multiple Myeloma Be Treated? That's a good one there. So make sure you tune in. I also want to note, we have open registration for the Black Myeloma or the Black Health Movement event. It's the weekend of August 15th and 16th. I encourage you to join. You don't have to be Black to participate in that. Everybody is welcome to come out and support. Um, that is a event to bring awareness to myeloma and other blood cancers that affect the Black communities, as well as to advance research. We have very low participation when it comes to African Americans participating in clinical research. So we want to advance research and help spread awareness of these blood cancers within the community there. So that is open to everyone. I encourage you to click the link and join us, join a team, create a team if you haven't already, and help us spread the word about that event. And what do we got next? So we got that. Oh, we got the Connect to Cures event. Not forget about that one. So we're planning many community events. The Connect Cures is a free in-person event where you can connect with other patients, learn from local doctors, and discover key resources with our HealthTree team. We have already decided on 5 cities, and we're still coordinate those. At the end of May, so just a well, it's not even a couple of weeks. It's going to be here next week, I believe. We're going to be in Macon, Georgia. And earlier in June, we're going to be in Peoria, Illinois. Then Orlando, Florida, Harrisonburg, Virginia, and we're looking out in the California area there. So if any of those cities is close to you or close to where you live, we would be happy to have you join us, and we'd love to meet you in person there. If you have questions, don't hesitate to reach out about those. You can scan that QR code. You should see it there on your screen. It's also going to go out in this email along with the link to the recording there. So again, I want to thank our sponsors, GSK, Pfizer, Kite, Johnson & Johnson, and Amgen. And thank you for making this a strong community, being a part of this community. Thank you for your support. And I look forward to seeing you on a future webinar. Until then, bye guys. Thanks for joining.